Good morning, everyone. It is a particular honor this morning to introduce our speaker, who, as you know, is also our pediatric Grand Rounds leader every week. Today, she is both our leader and our speaker. Dr. Emily Borman-Shoap is an associate professor in our Division of General Pediatrics and Adolescent Health, DOGPA. She is also our pediatric residency program director and vice chair of education in our Department of Pediatrics. She completed her undergraduate degree at Carleton College and her medical degree at Washington University in St. Louis before coming to the University of Minnesota for residency in a chief resident year, and then she joined our faculty. Dr. Borman-Shoap is currently in her 11th year as residency program director, and she has focused much of her career on competency-based medical education through a leadership position in the National Medical Education Pilot called EPAC, Education in Pediatrics, across the continuum. She enjoys providing primary care for children of all ages, with a particular interest in children with complex healthcare needs, including mental health conditions. She served as the principal investigator on several consecutive years of grant funding through the Minnesota Department of Health for primary care training, totaling over $1.5 million. Today, she will be sharing a very cool initiative to improve education and training for pediatric mental health conditions.
All right, thanks very much, Dr. Borowski. It's my pleasure to give Grand Rounds today, and now I get to have the experience of speaking to a computer screen, and hoping you all out there in TV land are listening. We will have, I hope, a good chunk of time at the end for conversation. I think this is a topic that has really impacted pretty much every single one of us who's providing clinical care, and so I think there's going to be a lot of opportunity for idea sharing and questions and discussion. As I begin, I want to be really clear that even though it was just my name on the title slide, the project I'm going to talk about has really been an incredible group effort with a group of people that I am just so honored to call colleagues and coworkers, and have really led to the strength of what we're already doing and what I hope we'll be able to do in the future. So it's really been an interdisciplinary and interprofessional project. From the Department of Psychiatry, we have Katie Lingris, Amanda Schlesinger, Katie Cullen, Katie Steingraber, and Greta Alquist, our project coordinator. From the Department of Family Medicine, Christine Danner and Jerica Berg. From the School of Nursing, Mary Benbenek and Sherry Friedrich, and myself from the Department of Pediatrics. If some of them are able to be here at the end, I'll hope to invite them to join the conversation as well. I do not have any disclosures. If you would like to give our program money to improve mental health care for children, we will gladly accept it and do our best to use it well. So what I'd like to be sure to talk about today are certainly these three key objectives, really to talk about some of the things that have been proposed at a national level for how we might improve pediatric residency training in mental health. And I'll certainly touch on how we are trying to do that at a local level. Talk a little bit about an integrated behavioral health model and how that has benefits in the educational space. And then certainly all throughout making sure that we all are on the same page about some of the common emotional, behavioral, and mental health concerns that present to primary care. I would say this Grand Rounds will probably be part storytelling, part question, making, and at the end, I'll tell you about the project that we've been working on. So really for me, this project that really kicked off in January 2017, so about 6 years ago. The American Academy of Pediatrics, many leaders in medical education really recognized that there was a serious need for better preparedness to meet the needs of our patients in terms of their behavioral and mental health conditions. And bear in mind, this is well pre-pandemic. So even before the pandemic, we were recognizing that we needed to do better in terms of being prepared for careers in primary care and doing mental health. So, excuse me. It was about this time of year, and many of you can probably relate to coming back from the holidays, having an inbox that's quite full of messages. I was scrolling through and excuse me, I have a little bit of a cold, which I can't give you because we're virtual. So scrolling through my in basket, answering things, tidying things up, and I found a email chain with a bunch of names on it that I didn't really recognize, some that I did. There were psychiatry colleagues, some were Professor Emeriti of Psychiatry, some of our developmental behavioral peds colleagues. I also noticed there was a couple of state senators on this email chain. And this article was referenced, and the basic question was, what are we going to do about this? This is really, we're heeding the call to action. So what are we going to do about this? As a part of that sort of big seminal issue of pediatrics, they really tried to put forth not only a call to action, but also some recommendations about what residency programs might do to really try to improve mental health training. And one of the things they really talked about was trying to create a culture where mental health training experiences as well as mentorship with mental health specialists are prioritized. And some of the things that they called out as priority areas for residency programs to think about included encouraging child and adolescent psychiatry electives, trying to improve mental health training within required rotations. And for those who aren't as familiar with residency curriculum, there's a few places where you would really expect to find mental health training. All residents do a developmental behavioral pediatrics rotation, so that sort of by definition is going to focus on mental health. All residents have an adolescent medicine rotation, which certainly often has a quite strong mental health component, and our rotation here certainly has always had that. And then really making sure that structured didactics, such as new conference or academic half day, also are addressing mental health issues. And I would say at that time, we actually already had quite a few of those things in place back in 2017. We had one child and adolescent psychiatry elective that had been quite popular, spending time with our day treatment program, and it had a couple of other one-off experiences. The training within our developmental behavioral peds and adolescent rotations, I would say, was fairly robust. And we are really fortunate to have the academic half day curricular model in our program for structured education, where we had at least 1 or 2 sessions each academic year focused on mental health. So we thought we'd start with, what do we have already and what do we want to do to make it better? So various players from that email I had received and kind of reached out to other people we knew would need to be involved to improve training, just started meeting together. So myself, some of our DBP colleagues, some psychiatry colleagues, the state senator who had some connections and had always been really interested in supporting mental health actually came to several of our meetings. This is where I learned that the University of Minnesota has several government liaisons. And if you're thinking about talking to elected officials, you should probably loop them in. So our University of Minnesota government liaison came to some of our meetings as well to help just sort of guide us in thinking about, what would it look like for a medical team to partner with the state, for example, and try to have a new program or a new initiative put in place. And one of the things we really settled on is, although we had some things in place already, they were quite discrete. So a developmental behavioral rotation or an adolescent rotation is a chunk of 4 weeks that is time limited within your residency program. So you might sort of build up your skills during the time of that rotation, but then without practice and ongoing coaching, they may decrement over time and you may not be as comfortable. And so we really wanted to think about how could we design something that would be more longitudinal, that would really take into account that our residents, our faculty, our fellows are adult learners. And so what's really the most helpful for them is to be able to have access to the material in real time when they need it. And it needed to be really accessible. There were already some resources in place to get mental health consultation that I would say some of our trainees were taking advantage of, but they weren't always easy. And I think particularly the guidance of our family medicine colleagues and some of the things I had seen work through our EPAC program really got us thinking about integrated behavioral health. So having behavioral health integrated into the primary care setting, but really through an educational lens. So instead of having the behavioral health expert, they're integrated for providing clinical care, thinking about how could you have them integrated to provide education. And one of the things that really made this stick out for me was seeing the experience of our learners who come through the EPAC pathway. So for those who aren't familiar with EPAC, it's a continuum training experience where residents match into a pathway in their second year of medical school, and they have a really customized third and fourth year experience that's really heavily focused on pediatric care prior to their transition to residency, and they complete both medical school and residency here at the University of Minnesota. And as a part of the EPAC curriculum, they have something called a longitudinal integrated clerkship. That's a way of doing your medical student rotations where the different experiences are intermingled. It often tends to be more outpatient focused. So our EPAC trainees come to a pediatric continuity clinic every week, and they work with a child psychiatrist in the outpatient setting every other week. And really within the first year or two of EPAC, I started to notice that the medical students who were participating in EPAC just came through with a different skill set and a different comfort level for addressing mental health concerns in the clinic. They were ready to dive in and take on patients that sometimes even I, as an experienced provider, felt a little daunted by. And so it really got me thinking about how early experiences being coached and mentored by a mental health professional can really shape your clinical practice habits as a primary care provider. This model certainly is in place to some degree in family medicine curriculum as well. The way that residency curriculum are set up to some degree is dictated by our accrediting body, the ACGME, and the family medicine program requirements are more explicit about requiring access to and learning in an integrated behavioral health model. And so that tends to be a stronger part of most family medicine residency curriculum. So as we were meeting with this grassroots group and sort of brainstorming about, what could this look like, we really felt like we wanted to focus on creating a system where primary care learners in training could have real access to pediatric mental health teaching in the moment, particularly in that outpatient setting. So as we were kind of having these conversations, getting excited, imagining what it might look like, we realized it was going to cost money. I think that's the thing that I have learned, unfortunately, more and more as I have moved up into more administrative positions is you're going to have to figure out how to pay for these really important projects that you want to do. And you got to get creative and sort of think about any possible avenue. So we already had connections with a member of our legislature who was very interested in our project and had some guidance from our University of Minnesota lobbyist. We also really were trying to be broad in our connections. So our child psychiatry colleagues were really invaluable in connections that they had with NAMI Minnesota, which is the National Alliance on Mental Illness. And Sue Abderholden, who's in a leadership position at NAMI, was a really important mentor for us as we were thinking about what it would mean to go and advocate at the Capitol. And I do want to just give a special call out to Senator Greg Clausen, who was in those early meetings with us and was really just an incredible champion both for educational programs broadly, but also for mental health. So we certainly, I hope this will be an encouragement to all of you that even if you've never done any advocacy or government work before, you can just try it out and see what happens. So we met with Senator Clausen, and I can remember being in his office at the Capitol, and he just literally got out a yellow legal pad and said, well, how much do you think it would cost to do what you're trying to do? And he named a quite large sum of money that was very surprising to me. And turns out actually he was right now that we've been doing more grant writing and really getting the project off the ground. We worked on, language and got it crafted into a bill, and, really worked to try to make the case at the state that training pediatricians and primary care providers at the University of Minnesota was a wonderful investment for our whole state. And, many of our training programs are the feeder for who practices in our state. Our residency program, for example, probably supplies upwards of 70% of the pediatricians in the state. So if our U of M residents are better at providing mental health care, that's going to be better for the kids in the state of Minnesota. So it's a lot of work to try to take something from a bill that does not exist and actually get it moving through. It was also quite unorthodox what we were doing. Usually investment in the university would come as a part of a larger whole university ask that goes to the Board of Regents and has many months of getting approved and added to the list. There was also lots of strategy about, is this a health and human services issue? Is this an education issue? So I would say I learned a lot in that process. You have to get champions in both the Senate and the House. So there's companion bills. You have to go through key committees before it can even be heard. So unfortunately, at that time, back in 2019, the bill did not advance for the potential for investment, but I think we really made a lot of important connections. We started some conversations that have been ongoing, and I think it was a really wonderful opportunity for our trainees to see what it looks like to advocate directly at the Capitol. I will plug several times today our advocacy day at the Capitol for Pediatrics in partnership with Minnesota AP is coming up on March 14th. When we did Peds Day at the Capitol back in 2019, we happened to be there on a day when they were hearing one of these bills. And so our residents got to be in the audience as myself and others testified about the importance of improving mental health training. And I sort of at one point said, hey, if you're a resident in training at the University of Minnesota, please stand up. And 80 people in white coats stood up in a legislative hearing room, which was a really powerful moment. So I'm hopeful there's going to be more opportunities to advocate for the state to invest in mental health training that I'll allude to at the end of the talk today, and just an encouragement for all of us to use our voice for the things that we think are really important for child health. So we didn't get money from the states. That was a bummer, but we had really been working to codify, well, what would this really look like? What kind of investment would we need? Who would be involved? And around that time, M Health Fairview and the medical school were offering a number of grant programs to really try to get new initiatives off the ground and provide some startup money. And we were really fortunate to be selected for an academic investment education planning grant. And so that really allowed us to get the project that I'll talk about in the second half of the talk off the ground. And I'll just give you a little preview to our mental health consultation team, who are just incredible providers who I love working with, Dr. Steingraber, Dr. Schlesinger, and Dr. Lindgren. So you'll hear more about them later. So I started a little out of order with, we recognized that this was something we needed to do. We started designing a program and thinking about how we might fund it and put it into place. But I want to just step back and make sure we're all on the same page about why this is so very important, and really kind of reiterate what I think won't be news for many of you about the scope of emotional, behavioral, and mental health concerns in pediatric primary care. So about 20%, 1 in 5 of children and adolescents in the United States meet criteria for a mental health disorder. And of those kids, only 20% receive needed services, and children of color are served at even lower rates. An additional 16% have impaired functioning but don't meet a discrete diagnostic criteria. And then another 10 to 13% of parents have concerns about behavior that don't necessarily meet a specific diagnostic criteria, but they still need support to provide good structure and developmental opportunities for their child. There's, if you haven't checked out the NAMI website lately, I would really encourage you to do so. And they have some wonderful materials about the impact of the pandemic and just mental health broadly. And again, I think many of us who are frontline clinicians have really experienced this, but it's really sobering to look at the impact of COVID on our young people. 1 in 6 adolescents from 12 to 17 experienced a major depressive episode during the pandemic. 3 million teenagers had serious thoughts of suicide. And those numbers are probably even a little worse in the young adult age range, 18 to 25. 1 in 3 experienced a mental illness, and 1 in 10 experienced a serious mental illness. 3.8 million had serious thoughts of suicide. And we saw a tremendous increase in health-related emergency department visits, 30%. So you can see that even back in 2017, we knew that we needed action, and the pandemic really just was so difficult for so many people of all ages, but particularly for our young people. And primary care really provides an opportunity to close that gap in mental health services. So well child visits are really a wonderful touchstone where you can start to identify, possibly treat or refer children with mental health concerns. Almost 90% of children regularly visit a primary care provider, and most children under age 5 have seen a PCP at least a few times prior to going to school. Our professional organizations have really come out strongly in favor of regular social emotional screening, but that can be quite variable depending on clinical practice. And I think knowing what to do with the results of a social emotional screen is still an area of work for many of our primary care providers. We might not know how to utilize the screening results, or even if we identify a problem, we're really not sure where to send them next. And that can put primary care providers in a really difficult position. And I think certainly that can be something that can contribute to burnout. That's something that we've talked about a lot in our group, is that we're hopeful that better equipping frontline providers to meet the needs of their patients will actually really get at that fourth aim of the triple aim of quality improvement, which is provider well-being and resilience. Among pediatric residents, they certainly indicate that they lack training. So there was a large national survey around the time of those articles in 2017. 65% of residents say they lacked appropriate training in mental health. Almost half, 40%, said they weren't sure they could properly recognize mental health concerns, and more than half said they didn't have confidence in how to treat things. So knowing this background, we were really thinking about, how can we have better interprofessional collaboration? We had some experience with some collaborative case conferences called collaborative office rounds that had been really good learning opportunities, and continuing to think about just that sort of lack of access to real-time coaching to deal with mental health conditions was one of the main things we felt might be leading to this lack of confidence in recognizing and treating mental health concerns. As a part of our project, we've done an annual survey of learners in family medicine, in the family medicine and pediatric nurse practitioner training programs, and peds and med peds residents. These are just some of the skills and knowledge that we ask people about. And bear in mind, this is a 7-point scale. The numbers might be a little small for you, but the anchors were a score of 3 is slightly prepared, 4 is moderately prepared, 5 is fairly well prepared. So on none of our metrics did we even reach an average of 5, fairly well prepared. And some of the areas are really an area of need in terms of better educational opportunities. One in particular that stood out to me was helping a family create a safety plan if a child or young person has thoughts of self-harm. Our residents felt very minimally prepared to be able to address that situation, which we saw from the previous slide, just quite common. Almost 3 million teenagers in 2020 had serious thoughts of self-harm. We also know that both our residents and our faculty are definitely seeing these patients. The orange bars are residents and the blue bars are faculty. So in a given month, most faculty are seeing either 11 to 20 or more than 20 encounters that involve a mental health diagnosis. And really most of our trainees are seeing somewhere between 5 and 20 patients per month with mental health concerns. We know these patients are arriving at primary care and sometimes they may need a referral. One of the challenges is that our mental health workforce is really overstretched. The lighter colors on these maps show areas with no psychiatry coverage or very limited psychiatry coverage. So it's really a recognized need that we know that it may be quite a long wait for someone to get in to see a mental health professional. And so the more a pediatrician can do to get care started, to recognize a problem and make a timely referral, the better it's going to be for the patient. This is not just a Minnesota thing. This is a national issue. So you can see lots of gray boxes with 0 psychiatrists in many counties and regions across the country. We had seen in 2017, the AAP was already recognizing the really serious mental health needs, and certainly the pandemic just really hammered that home. So the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association came together to declare a state of national emergency in child and adolescent mental health. This was in April of 2022. And if any of our emergency department colleagues are tuned in today, you wouldn't need the AAP to tell you that. In our own hospital, we have experienced huge surges of patients who can't find appropriate placement and care for their mental health needs. And I think that I just applaud our care teams for being so creative to try to keep our patients safe and get them the help that they need. And I think we all hope that we can figure out ways not to get to this point again. One of the things that is always really powerful for me is just really bringing it back to the voice of our patients. And so I'm going to share a few quotes on the next slides that are from patients who have come to see me. This is just over the past 6 months, but sort of moments that really stood out for me as moments where a young person was really articulating their need for help and how difficult things had been for them. It's like a pipe has broken and I just can't stop the flood. I just want to feel something. I'm not really having fun anymore. Sometimes I think it might be better if I wasn't alive. So we know that young people are struggling and need better help from their primary care clinic and to get plugged in with mental health expertise as soon as possible to get the help that they need. And so now I'm going to transition and talk a little bit about the project that we've been able to pilot and share some of our early successes and what I hope will really open up conversation and questions from all of you. So as I mentioned, this is our team of consultants, and they're providing teaching and services to pediatric residents, family medicine residents, and advanced practice nursing trainees. Currently, because our project started through an mHealth Fairview grant, we've focused on trainees who have their outpatient primary care clinic at mHealth Fairview Children's Clinic and mHealth Fairview Clinic at Bethesda. And we really have two kind of main educational delivery models. One are the case-based consultations, and then the other is a series of educational tools, some really high quality monthly newsletters that we put out that have been, I would say, really informed by the kinds of conversations that we're having during the case-based consultations. I think our consultants have done an incredible job of noticing, gosh, a lot of people are asking me about sleep or about anxiety. Maybe we should pull together some resources and send them out. So these are really high yield 2 to 3 page email digests that have some quick pearls and then places where you can go to learn more. If anyone who is tuned in today would like to be subscribed to our listserv, you can just shoot me an email and we're happy to get you added. Those have been I think, really valuable and easy to access tool that gets pushed right to your inbox. So topics that we have covered include summertime anxiety. Certainly I think every time we turn around, there's seems to be something really tragic or difficult happening in the news. So we've provided some guidance about how to talk to kids about things that are hard or scary or serious events. Sleep issues, anxiety, bullying. And we've had pretty good reach with our newsletter. So we use MailChimp to deliver them. You can see that most of our newsletters are read by somewhere between 150 and 200 people. Some of our most popular issues, we had one about provider well-being resilience called "You Can't Pour from an Empty Cup" that I think got shared pretty broadly. And also sleep advice was a really popular issue. Now I want to pivot into talking about our case-based consultations, which I think is really where the magic is happening, if I may call it that, in our project. So each of our consultants has protected time to be available to really be embedded in the primary care clinic. So a resident in training or nurse practitioner in training will go and see a patient or might be looking at their schedule and anticipating a concern that may come up. And they're able to get teaching and mentorship in real time from a mental health professional to really think about how to best meet the needs of that patient. Is there another screening tool that should be used? Are there certain ways of taking the history or asking the questions for this patient? How would you explain therapy to this patient or the different types of therapy that may be helpful for them? To date, we're about 2 years into the project and we are nearing 400 consults completed. Some of our most common topics that are consulted about include anxiety, depression, self-harm, and suicidal thoughts. Our medical residents and the preceptors have access to this service and I think have had high utilization. We're still really thinking about how to make the service more available to our nurse practitioner trainees who may be scattered in more care areas for their clinical experiences. I mentioned that anxiety and depression are some of the more common topics, but this is an early data pull, and you can see we're really talking about a huge range of child mental health issues from ADHD to autism spectrum, sort of general basics of, what is therapy, who benefits, what are the types of therapy, sleep issues, substance abuse. Most of the consults are pretty brief, so you often connect with the consultant, get a little real-time coaching that probably takes less than 10 minutes or 10 to 15 minutes. And then you're ready to put some things in place for your patient that very afternoon. Each of our consultants is always available both in person at the clinic where they're posted for that day. And then I think partly because we started this project in the pandemic, we had to get really creative. And so we created an infrastructure for virtual consultation that we've been able to really keep going pretty effectively during the course of our project. So about 30% of our consults are virtual. Some of the consultations are maybe more subject-based, a question about a medication or a general topic. but our consultants are also certainly have time to actually dive into the chart along with us. I would say I certainly have found that to be incredibly valuable because there was a bunch of really high yield information about mental health treatment planning that was hidden in this section of EPIC that I wasn't as familiar with, and I learned about it from Dr. Schlesinger. So I think that, and I'll allude to that a little bit later, I think that sort of co-learning and teaching each other about our care areas and the way we do things has also been a hugely valuable part of the bidirectional learning. We've been trying to talk about what we're doing. So we've presented at 5 national conferences and are really working to make connections with other training programs who are trying similar projects. We have 1 manuscript published already and are working on others. We had some early funding from Medica. We have that AIEP grant right now. And we're actually really fortunate to just be selected for a Minnesota Department of Health healthcare expansion grant, really focusing on how to bring the sort of robust teaching that the medical residents have been able to take advantage of and making sure we're expanding it effectively to our nurse practitioner learners. And I think we're really building a model for collaboration. It's really a bridge from primary care and the community to specialty mental health care. I think it has been instructional in both ways, right? The mental health professionals can really see the reality of the everyday flow and challenge of a primary care setting. And we really get to understand all the different care team members and places that are available to help meet the mental health needs of our patients. We end up talking about a lot of practical things. We're frequently looking at how the mental health referral is set up in EPIC and how can we make it better. That's a not infrequent email that we'll send in clinic is, writing to someone and saying, hey, we want to refer a patient, but it's actually really tricky to do that. Can we make this process better? So I think there's a lot of systems and quality improvement work that's coming out of this that's a little hidden, but maybe we'll try to find a way to quantify that as well. And I would say, really future directions for us is really trying to demonstrate the benefit that this is having. I can see it as the provider who has access to this consult service. I know that we're starting care earlier for patients who need help. I think our trainees who have access to the service are really building their skill set in a way that's different and exciting and are ready to take on more care and really trying to think about how to demonstrate to our health system, maybe demonstrate to payers, that sort of upstream investment. How does it look to invest in prevention in mental health to prevent that overflowing emergency department 6, 9, 12 months down the road? We're really continuing the legislative advocacy avenue. We've been really fortunate, I think, to find a lot of champions in the state legislature. At our advocacy day in 2022, we invited some different elected officials to come to Minnesota AP's Day at the Capitol, and Representative Dave Baker has really been a champion for mental health conditions, and particularly substance use disorder is a big interest of his. And he was at Pete's Day at the Capitol and was really interested in the things we're doing. And I said, you should come talk more about it sometime. And he said, sounds great. And so we just set up a visit, and he came to Masonic Institute for the Developing Brain and had a tour and had a conversation. So we're really trying to continue to make those connections with our elected officials who may be interested in investing in mental health training. All of our residents in the audience certainly are going to be attending Pediatric Day at the Capitol, but I just want to put out a plug for all of our faculty or students who may be tuned in. Go check out the Minnesota AP website. Anybody can attend Peds Day at the Capitol, and it's really an opportunity to share with your elected officials the issues that you think they need to be paying attention to. So thinking about how to fund this important work also remains a focus for us. I alluded to our partnership in kind of collaboration with NAMI, and one of the things I just learned is they have a large mental health care workforce bill that they're going to be proposing that may in fact include some potential for funding for residency and primary care training programs, which is really exciting. So there'll probably be more to come on that front as well. All right, so as I promised, I wanted to leave lots of time for questions and conversation. I'm going to please go ahead and put them in the Q&A or in the chat. And I'm just going to look and see if some of my buddies from my team have been able to join, and I'll promote them up to panelists so you can see their wonderful faces as well.
So Emily, can I?
Yes, you can ask a question while I do that for sure.
Thank you. One of the areas you touched on was the EDs and the challenges there. It made me think about training in fellowships and mental health training in fellowships. I know when I did my HEMONC fellowship, I didn't have any mental health training during my HEMONC fellowship. Are we getting this integrated into the fellowships as well?
To some degree, but I would say that is certainly a really great growth area for us. And I think I'm actually really proud of our department for doing the mental health screening that we do in the outpatient subspecialty setting. I know when we were rolling out the, depression screening, that's, not typical that it's done at every clinic visit. And so I think probably a lot of the people on the call have had to deal with an abnormal mental health screen in the subspecialty setting. And so I think that is probably a next frontier for us. I'm going to pause and thank you for, I'm going to scroll the list for other team members, but I want to just take a minute to introduce Dr. Katie Steingraber, who is a child psychiatrist, and Dr. Christine Danner, who is a psychologist. So maybe Katie, if you want to start first and just introduce yourself and share a little bit about your clinical practice and any reflections on the project so far.
Yeah, good morning, everybody. So clinically, I spend some of my time, of course, as a consultant at both the Bethesda Clinic and then the Fairview Children's Clinic. In my own clinical practice, I do a little bit of work actually in the pediatric subspecialty clinic, the pulmonary clinic. So I work with the cystic fibrosis population there, and then spend a lot of my own clinical time working with patients with neurodevelopmental disorders, genetic conditions, and complex medical conditions. So that's a little bit about what I do day to day. I would say that my time doing this consultant work has been some of the most, I've had some of the most meaningful interactions, because I've both learned a lot myself, as well as I can see from the pediatric residents and faculty actually that they're taking away a lot. And I think that the sort of the win-win on both sides has been really lovely.
Great. And Dr. Danner, do you want to introduce yourself and a little bit about your clinical practice and your reflections on the project?
Sure. So I am the Director of Behavioral Health for the Woodwinds Family Medicine Residency Program, and I've been in that position for a little over 20 years. So family medicine has a requirement for a behavioral health faculty. And so despite that, there is still additional need, is what we were finding, for even more specialized training around especially early childhood mental health. So I'm a generalist, more adults than kids. And so even with a dedicated behavioral health faculty, we were finding there were gaps in knowledge and need for additional skill building. So it's been really fantastic to be able to add the pediatric IBH team and have child psychiatry as well as child psychology participate in the education of our residents. So that's a little bit of my role. So more is always better. In my experience.
So actually, can I add just one quick thing?
Yes, please.
So although you have introduced a lot of the members of our team, I would just say, to clarify from what Dr. Danner just shared. So I'm a child and adolescent psychiatrist. So is Dr. Schlesinger. I think what's really unique about our about our team is that we also have a child psychologist who is part of the consulting group. And so I think there's a lot of learning to be had from both of those specialties, and we're able to offer that. in like real time in clinic. So Dr. Lingris isn't with us today, but she is a child psychologist and offers a lot of expertise that I don't have, and neither does Dr. Schlesinger. So.
Yeah, I think that, I mean, for me, being a part of this group has been an incredible resource. And I think just the different expertise and approaches to care really makes a whole package. And I think that has been a real strength of our group for sure. Dr. Marmet asked us about the survey that we do about resident comfort. We haven't broken it out by year, Jordan, but we can do that. That's probably part of our data analysis and survey write-up. So if anyone in the audience is looking for a project, certainly reach out. We can put you to work. We do it every year in sort of September, October. So sort of recognizing that an early intern may have quite limited experience, but we know that some interns coming in have worked as a, patient care aide on a mental health unit. So they may actually have a lot of experience. So there more to dig into sort of what the local factors that drive experience. Dr. Bullock was just sharing that screening for mental health concerns that they're doing in the subspecialty clinics is undergoing some rework. So there's probably more to come there. Peter Scale asks, can you share what you're learning about the common concerns that clinicians already have too much to do and not enough time to do it? I think the thing that's certainly been so helpful for me as a provider, and I would say the same for the residents, I suspect would say this, is the ready access to the consultant, right? Like you go to the door, you pick up the team screen, you see that there are concerns, and before you even go in the room, you can make a game plan with the consultant. Okay, these are the things they're saying. How can I best address this in a kind and efficient manner to make sure the patient gets what they need today? So I think it's actually helping people to use their time much more wisely because they're better equipped to address the problem that has come up. I don't know if Katie or Christine, if you have any examples where you've sort of seen that it seems to be helping people to get to the right path more quickly.
I wasn't sure if you wanted to take that one first, Katie, or not. Time is always the monster in the room, right? It's always the thing that we're up against in primary care. And so I think as a successful consultant, you always have to keep that in mind. And I always appreciate that our consultants do keep that in mind in terms of what is the teaching moment and how can that make the work more efficient. But yeah, that pre-visit planning that can go into like being ready for that next visit can actually help it be much more efficient and get to the most important things. So time is always a barrier. And yet I agree that the consultation can be mindful of that and help streamline the process.
Yeah, and I would add to, I think one of you just mentioned about like the clinic prep, right? So I certainly have had a number of residents and faculty send me a quick message in Epic. Hey, you're going to be here tomorrow. My 8 o'clock patient, I have a question about X, Y, and Z. Can you be ready to share resources with me tomorrow morning? And then we can have a very quick conversation about it. I'm prepared to answer the questions they have, right? And then they can walk in and see the patients and feel like they have a much more robust treatment plan to offer. I would say the other area I've seen this kind of play out is maybe not so much an efficiency, but sort of getting back to the question of the common concern that clinicians already have too much to do and not enough time to do it in. So I think sometimes in primary care, it's a really big learning experience for me to just see sort of like the pace and the volume, right, that you are managing on a daily basis, right? And sometimes the concern to sort of have like the patient comes in, the family comes in, and they really are requesting something today, right? And then the knee-jerk reaction is like, how am I going to help them today in this very short visit? And I think some where I think I've been able to be helpful is helping the residents think about it in the framework of like, this maybe isn't something we can address entirely today, and how can we use the right language to help share that with the family that in fact we'll bring you back in a couple of weeks and then a couple of weeks after that, and this is what we're going to do at each visit, but to actually break it out so that you're feeling like maybe you are doing a little bit less in each visit, and that feels more manageable too, I think, for the residents and faculty.
Yeah, I think that's a great point, is just sort of giving permission that you're not going to fix it all in that initial visit, but here's a typical rhythm for managing a mental health condition as an outpatient. Here are the things you can get started today, and here's what it looks like to make a plan with a family going forward. And I think that's been hugely helpful. Yes, I would agree, Peter. Being prepped just makes the visits much more efficient. I think certainly being able to get advice about medication management is hugely helpful. You know, the difference between digging around and up to date and trying to find some nuance about sertraline dosing versus turning to an expert and saying, well, what would you do with this dose, is, you know, just sort of incomparable. So I think that's been really helpful, as well as for patients for whom we're starting medication management for a mental health concern. We've really been lucky to have a lot of expertise to draw on. Dr. Marmet asked about the educational conference series called Collaborative Office Rounds that has been a regular offering on and off at the university over several years. And I think a lot of the sort of foundational ideas for how we designed this project came from experiences in Collaborative Office Rounds, seeing that benefit. Collaborative Office Rounds is really geared towards having primary care providers, mental health professionals together talking about cases and how you might manage them. And I think, you know, this is sort of like core on steroids. It's core every week when you're in continuity clinic, but I think that really gave us some proof of concept about teaching models that can be really effective for primary care providers. All right. Feel free to put any further questions in the chat. As I mentioned, if anyone's interested in subscribing to our Pearls newsletter, we'd be happy to add you to our list. It's really great content that goes out once a month. And certainly welcome, you know, follow-up questions or discussion. Even if you're not a primary care provider, I think, as we mentioned, this is touching all aspects of care, whether you're emergency medicine or a subspecialist. Peter, we've not included mental health trainees in the consultation groups yet, but I think it's really ripe for that. And I think, you know, just that sort of bi-directional learning of seeing the reality of the day-to-day clinical life of the people who make referrals to you, I think is quite helpful. That's something we've talked about a lot on Wednesday afternoons when I'm in clinic. So that's a area of future consideration for us as well.
And with that, I can just say we do have doctoral level behavioral health fellows at Bethesda. And so those trainees are folks that we also have folded in our PEDS IBH consultation providers into our interdisciplinary team meetings. And so fellows are a routine part of that, so they can access that education there, or when they're in clinic, I also think consult our PEDS IBH consultants. So if you happen to have mental health trainees in your setting, that's a great option.
Thanks. Dr. Scheuer asked about if we are tracking faculty comfort level and knowledge. We are. The annual survey that we do also includes faculty, and we'll be able to sort of tease it out by which clinic we're at, so people are at. So we'll be able to compare both faculty and preceptors who've had access to the consultation service and people who are working in a more typical primary care setting. And I think that's absolutely the case, that the preceptors are learning at least as much, if not more. And I think that's huge, because if your teachers aren't comfortable in their own skills, how are they going to supervise you in doing the work? So I think that certainly is a challenge as we're trying to improve mental health care and primary care. Is it's not just, you know, each graduating class of, you know, 25 PEDS residents or, you know, 10 family medicine residents. It's all the people who came before them who maybe wish they had more training and more confidence in their ability to provide mental health care. So that's something we Yes. Hello, Dr. Jensen. We love having retired child and adolescent psychiatrists on a voluntary basis. We'll be in touch. There aren't very many of you. I think that is one of the main problems that we face, is just the workforce is small. And so I think, we hope that investing what is really a big chunk of time on the part of our consultants is helping to obviate some of those huge wait lists down the road, because care gets started sooner. Things are identified when they're a little bit of a problem and not a huge problem. Wonderful. Well, thank you all so much for being here with us today. I'll put in another plug for our PEDS faculty. Please come to the Julie Ross event tomorrow evening. It's going to be a really wonderful chance to connect with one another. Don't forget to log your attendance and get your MOC Part 2 credit. And we will see you back next week. Thanks for being here, everyone.